Welcome to our video on placental abruption, Placenta Previa, and Vasa Previa. Let's get started. Here is our overview slide. Let's begin by discussing placental abruption. With regards to this topic, we'll be discussing the definition, risk factors, clinical features, complications, diagnosis, and management. Let's start with the definition. Placental abruption is the premature separation of the placenta from the uterine wall. This separation can be partial or complete. The most important risk factor for placental abruption is a history of previous abruption. Other risk factors include maternal hypertension, preeclampsia, and eclampsia. Smoking and cocaine use also predispose to placental abruption. And the final risk factor to be aware of is abdominal trauma. Placental abruption classically presents with sudden onset third trimester vaginal bleeding accompanied with severe abdominal or back pain and frequent uterine contractions. Here's an image from our partnership with AMBOSS, which highlights the different types of hemorrhage in placental abruption. The middle image shows revealed hemorrhage, which is classically seen in placental abruption. This is not always the case though, and hemorrhage may not always be evident. And if it's not evident, this is called concealed hemorrhage, also known as retroplacental hemorrhage, which occurs as the blood accumulates in the space created between the separated placenta and the uterus. Patients with retroplacental hemorrhage will present with signs of shock without evident vaginal bleeding. Sometimes a mixture of retroplacental hemorrhage and vaginal hemorrhage occurs, and this is referred to as mixed hemorrhage. Important complications of placental abruption include fetal hypoxia, fetal demise, and preterm delivery. Patients are at a risk of developing hypovolemic shock due to hemorrhage and DIC. Placental abruption weakens the uterine myometrium and therefore increases the risk of future uterine rupture in subsequent pregnancies. Placental abruption is a clinical diagnosis. The physical exam will reveal a tender and rigid uterus, and it's important to know that a digital vaginal exam is contraindicated because it may worsen the bleeding. Ultrasound can be performed to rule out a placenta previa or to look for a retroplacental hematoma in case of a concealed abruption. Fetal heart rate monitoring will show signs of fetal distress with late decelerations due to placental insufficiency and hypoxia. The management begins with stabilization of the patient. Fluid resuscitation with crystalloids, monitoring vital signs, and maintaining the airway are essential. Patients in hemorrhagic shock should be placed in the lateral decubitus position and should be given blood transfusions. After initial stabilization, RHD prophylaxis should be given to Rh-negative mothers due to mixing of maternal and fetal blood. In case of mild abruption and a premature fetus, manage expectantly. In moderate and severe abruption causing significant bleeding, immediate delivery is required. If both the fetus and the mother are stable, vaginal delivery can be attempted. If the fetus is in distress or the mother is unstable, a C-section is indicated. All right, let's practice with a question. A 29-year-old woman at 34 weeks of gestation is brought to the emergency department due to acute onset abdominal pain and vaginal bleeding. On physical exam, the uterus appears tender to palpation and continuous dark vaginal bleeding is present. She is tachycardic and her extremities are cool to the touch. The fetal heart rate shows late decelerations. What is the most likely diagnosis of the patient? What are the risk factors associated with this patient's condition? All right, so this 29-year-old woman is presenting in her third trimester with vaginal bleeding and abdominal pain. The physical exam shows a tender uterus and fetal distress. This, along with signs of hypovolemic shock, such as tachycardia and cool extremities, make placental abruption the most likely diagnosis. Remember that placental abruption is a clinical diagnosis. Important risk factors for this include previous abruption, maternal hypertension including preeclampsia and eclampsia, smoking, cocaine use, and abdominal trauma. All right, now let's move on to discuss Placenta Previa. Again, here's the sequence of topics in which we'll be discussing Placenta Previa. Let's begin with the definition. Placenta previa occurs due to abnormal implantation of the placenta over or in close proximity to the internal cervical os. Here's an image from our partnership with AMBOSS, which demonstrates the different levels of placenta previa. These include a low-lying placenta, marginal placenta previa, partial placenta previa, and complete placenta previa. The lower part of the images represent the view of the external cervical os with a speculum exam. In low-lying placenta, the internal cervical os is 2 centimeters or less from the lower edge of the placenta. In marginal placenta previa, the placenta reaches the internal cervical os. In partial placenta previa, the placenta partially covers the internal cervical os, and in complete placenta previa, the placenta completely covers the internal cervical os. The most important risk factor of placenta previa is a history of previous placenta previa. Other risk factors include factors that cause uterine scarring, such as a C-section and uterine surgery. Additionally, multiparity and advanced maternal age are other risk factors. Placenta previa presents as profuse, painless, third trimester vaginal bleeding. The first episode usually stops within 1 to 2 hours and reoccurs during birth. The first episode of bleeding occurs due to the thinning of the lower uterine segment during the third trimester, which disrupts the placental attachment. Note that this bleeding is maternal in origin and therefore does not cause fetal distress. Remember that digital vaginal exams are contraindicated in patients with vaginal bleeding of an unknown etiology, although a speculum exam is considered safe as it does not penetrate the cervix. Ultrasound examination, specifically transabdominal ultrasound, followed by a transvaginal ultrasound, can assist in the diagnosis. It's important to note that placenta previa is usually diagnosed prenatally. Therefore, patients will have a known history and should be followed up with an ultrasound in the third trimester to see if it is resolved. Patients with a confirmed diagnosis of placenta previa who are asymptomatic can be managed in an outpatient setting with pelvic rest, and this refers to avoiding sexual intercourse. Symptomatic patients require hospitalization and continuous fetal monitoring with IV access. An immediate C-section is indicated when there is active and unstoppable labor, severe bleeding, or fetal distress. Finally, vaginal birth is contraindicated due to the high risk of severe bleeding. Here is an algorithm that discusses the management in more detail. When a patient presents with signs and symptoms of undiagnosed placenta previa, such as painless third trimester vaginal bleeding, a transvaginal ultrasound should be performed. And this will show a placenta that is 2 centimeters or less from the internal cervical os. After the diagnosis has been confirmed, to determine the appropriate management, you need to look at the fetal gestational age. If the gestational age is more than 37 weeks, immediate delivery with C-section is indicated. If it's less than 37 weeks, you need to assess the presence of fetal or maternal distress or the presence of active bleeding. If any of those are present, stabilization of the patient and C-section are indicated. If there is no fetal or maternal distress or active bleeding, the patient can be managed expectantly. If the fetus is less than 36 weeks of gestation, corticosteroids for lung maturity and tocolysis are indicated. If the fetus is extremely premature, less than 32 weeks of gestation, additional magnesium sulfate is required for neuroprotection. All right, let's try another question. A 33-year-old woman, gravida 4, para 3, at 35 gestational weeks, comes to the emergency department due to painless vaginal bleeding. She says she had a previous episode of vaginal bleeding 2 days ago that resolved on its own. Physical exam shows active, bright red vaginal bleeding. Her blood pressure is 87/57 millimeters of mercury, and her pulse is 120 beats per minute. What would most likely be evident on transvaginal ultrasound? After stabilizing the patient, what is the best next step in managing this patient? All right, so this 33-year-old multiparous woman is presenting with active, painless, third trimester vaginal bleeding. Bright red vaginal bleeding is seen on physical exam. She appears unstable and is hypotensive as well as tachycardic. All of these findings makes placenta previa the most likely diagnosis. A transvaginal ultrasound will show placenta covering the internal cervical os. And after stabilizing the patient, the best next step in the management should be to perform a C-section as there is active bleeding and the mother is unstable. If there was no active bleeding and the mother and fetus were both stable, then expectant management would be more appropriate. All right, let's finish up by discussing Vasa Previa. With regards to this topic, we'll be discussing the definition, pathophysiology, risk factors, clinical presentation, diagnosis, and management. So let's start with the definition. Vasa Previa is defined as fetal blood vessels crossing or passing over the internal cervical os. It most commonly occurs due to congenital placental anomalies, such as velamentous umbilical cord insertion or multiple lobed placenta. This leaves vessels unprotected and prone to shearing, laceration, and bleeding. Here is an image that depicts the velamentous umbilical cord insertion with and without the presence of Vasa Previa. Under normal circumstances, the umbilical cord is inserted into the middle of the placenta. Velamentous cord insertion is a pregnancy complication where the umbilical cord is inserted in the fetal membranes instead of into the middle of the placenta. The middle image shows velamentous umbilical cord insertion without the presence of Vasa Previa. And the last image shows velamentous umbilical cord insertion with Vasa Previa. Note the exposed blood vessels in both images with velamentous cord insertion. Pay attention to how the vessels cross the internal cervical os in the case of velamentous cord insertion with Vasa Previa. Here's an image that shows multilobed placenta with Vasa Previa. Note that both velamentous umbilical cord insertion as well as multilobed placenta can cause Vasa Previa. As I just mentioned, placental anomalies such as velamentous umbilical cord insertion and bilobate placenta are risk factors. Note that advanced maternal age and in vitro fertilization are also risk factors for developing placental anomalies. And the final risk factor to be aware of for Vasa Previa is multiparity. Okay, moving on to clinical features. Vasa Previa typically presents a sudden painless vaginal bleeding that occurs with rupture of membranes. Variations in fetal heart rate occur, such as decelerations, fetal bradycardia, and a sinusoidal pattern, which all indicate fetal distress. Recall that the sinusoidal pattern refers to a fetal heart rate wave resembling a sinus wave. It's important to know that complications may occur due to severe bleeding, which can lead to fetal death. Fetal asphyxiation can occur if there is pressure on the unprotected vessels. Vasa Previa is ideally diagnosed antenatally. Doppler ultrasound is the gold standard, and transabdominal or transvaginal ultrasound will show fetal blood vessels crossing over the internal cervical os. An emergency C-section is indicated in case of acute bleeding and fetal distress. If Vasa Previa is diagnosed antenatally and the fetus is less than 32 gestational weeks, steroids can be administered to induce fetal lung maturity. If the fetus is between 30 to 32 gestational weeks, hospitalization for monitoring and scheduled C-section are required. In uncomplicated Vasa Previa, scheduled delivery can be attempted at 34 to 35 weeks. Here is a table that summarizes the information we've discussed in this lecture, so feel free to pause the video and review this. Let's finish up with a final question. A 27-year-old woman with known Vasa Previa comes to the emergency department due to profuse painless vaginal bleeding with rupture of membranes. She appears unstable with tachycardia and hypotension. The fetal heart rate shows fetal bradycardia. What is the best initial step in the management of this patient? All right, so from the question stem, we know that this patient has Vasa Previa. Now she is presenting with profuse painless vaginal bleeding with rupture of membranes, which is typical of Vasa Previa. The fetal heart rate typically shows tachycardia followed by bradycardia. The best initial step in managing this unstable patient is to administer IV fluids for stabilization. It's important to note that the administration of IV fluids is the best initial step in the management of all unstable patients with antepartum hemorrhage, regardless of the underlying cause. And that concludes our lecture on placental abruption, placenta previa, and Vasa Previa.